Good morning, everyone. Hope everyone's having a great time at the conference. I am Alice Park, Senior Correspondent for Time, and it is my pleasure to introduce Administrator for the Centers for Medicare and Medicaid Services, otherwise known as CMS, Chiquita Brooks-LaSure. Now, to give you a sense of the scope of Chiquita's job, CMS oversees Medicare, Medicaid, the Children's Health Insurance Program, or CHIP, and the Affordable Care Act health insurance marketplaces. So that means 88 million people covered under Medicaid, half of whom are children, 65 million covered under Medicare, and this year, currently, that's 100,000 more people than the previous year, to my understanding, which represents 20% of the US population. And given the way we are living longer, estimates are that by 2050, the population in the US that's over 65 will double. So that means you've got a lot more people under your care. So I am excited to have this discussion this morning with you, Chiquita, because it's been an especially busy year at CMS. And not only do you have responsibility for basically half of the American population's health, you're leading the agency through a number of very historic firsts. So I thought we'd start by getting to know you a little bit better and tell us about what got you into public health policy.
Well, first, let me just say it's a pleasure to be here with you all and getting to talk about the incredible work that our agency is doing. I started in public policy in the Washington, D.C. area in Georgetown, and really was excited to go there because you actually get to work with people who are policymakers. You can do internships. Some of your professors are work in the field. And I had two professors who co-taught a class. It was a social policy class. One was teaching more about welfare programs, and the other, Professor Judy Fader, taught health policy. And once she got to know me, she said, "You are going into health policy." And I think I really, at that point in my life, was very mission-driven, wanted to do work that really would help change people's lives. And I really wasn't as focused on health. I had been very interested in the sciences, had thought about med school, but increasingly had a different appreciation during graduate school of how much health really determines your ability to achieve the American dream. So when we think about children, and at the core, especially then, my heart was for the children of our country. You can't take advantage of education if you aren't healthy, if you're worried about your sick family member. And so from there, I just got very passionate about health policy. And my first job out of graduate school was working in the Office of Management and Budget. I was career at the end of the Clinton administration, the beginning of the Bush administration. And I worked on the CHIP program right after it passed and got to meet families. I remember my first site visit was to Montana, and just the excitement that some of the parents had to have a card that meant their kids could have coverage. And then September 11th, I was also there, and the administration, the Bush administration, was trying to think about how do you cover people who have lost their jobs, dislocated workers. And so I worked on what is now called the health care tax credit, and really got to appreciate that there are many ways to ensure that people have coverage, but how important it is for people to have coverage. That's my core, really wanting to make sure the American people have access to what I like to say, either one of the 3 M's, Medicare, Medicaid, and CHIP, marketplace, or employer-sponsored insurance, because I think it's core to, as I said, achieving the American dream.
And you moved to CMS when?
My first visit to CMS was during the Obama administration. I worked in what was called CSIO. It was, I had been at the department, I had first been at the Ways and Means Committee, and then moved, once we passed the Affordable Care Act, couldn't let the administration have all the fun and implement. So I came to HHS and then went to CSIO, which is a part of CMS, in 2013, the beginning of 2013. And then I came back in this role when I was appointed by President Biden and confirmed by the Senate just a little over 3 years ago.
Okay, we're going to come back to the Affordable Care Act and the critical role that you played in that, as well as kind of how that informed the work that you now do at CMS. But I wanted to also get into, before we leave kind of the context and the history, get into a little bit of the history of CMS as an agency and the important role it plays in influencing health in the country and shaping the way our healthcare system looks right now. And I was very surprised when I learned this, but tell us about one of the kind of early milestones in CMS history.
One of the things that I think is so meaningful and really demonstrates how important our programs are is the role that Medicare has played. And Medicare is the reason why hospitals in this country are desegregated. And I like to remind people this is not ancient history. When my daughter was born, we were at a hospital, which is in right outside Virginia, or it's in Virginia, right outside DC. And my husband was talking to what some of the women in, I don't know exactly where, I was kind of occupied with delivery. And they were women who were in their 60s who were Black, and they talked about how they grew up a mile away from that hospital, but their mothers were forced to give birth in DC because the hospital where I delivered my daughter was not desegregated. And so I think that this story reminds us that public programs, and particularly the Medicare program, have an amazing ability, and I would say almost an obligation, to make sure that we in our healthcare system are treating the underserved. And that's one very important example of the role that the Medicare program has played in this country.
And Medicare was the one that said they wouldn't reimburse, right, at hospitals that were not desegregated.
Exactly.
So that really set a precedent for if people wanted to get money for the services they provided, right? Healthcare services they provided, they needed to be desegregated.
That's right, and it shows today. So often I get asked about what Medicare is doing, not just from people who depend on the Medicare program, but also people say the commercial market follows some of the things that are important to Medicare. Recently, someone said to me, from a Medicaid point of view, I heard you're doing something on primary care in Medicare. I hope so, because states are interested and very focused on what you do in the Medicare program. So again, I just think its role is incredibly outsized, and that's an important thing for us all to understand, and certainly something that I and the team at CMS take very seriously as we think about policy and operations.
And speaking of that outsized role, I think one of the big topics in healthcare today obviously is drug pricing, and CMS plays a very important role in that, especially in this past year with the first kind of negotiated drug pricing program. Can you tell us a little bit about that and where it stands? I know it's kind of phasing in, right, over this year, 2025 and 2026.
Absolutely. I mean, I feel so privileged to be here in this role, in this historic moment. I think it's surprising, but it's worth remembering. When Medicare was created, it didn't cover drugs very much because drugs weren't a big part of how you got health care back then. And
this was in the 1960s, so not
exactly.
that long ago, right?
It wasn't that long ago, but medicine has changed tremendously in a good way. There's so many more innovative products to market, and it wasn't until 2003, so a little over 20 years ago, that Medicare covered drugs much more broadly. But there was a big disagreement about whether Medicare would negotiate, and CMS was not given authority to negotiate the same way that some of the other agencies do. I would say, and you can imagine just how many questions I get asked about and how much people care about. I don't think there's a question that I get asked the most about except drug pricing, and just what a struggle it is for our nation's seniors and people with disabilities, many of whom are on multiple medications and really struggling to afford them. I am sure all of you could tell stories, but I think not only does it affect health, but it affects choices, like hearing from a woman in North Carolina who was talking about how she couldn't retire because her husband was on Medicare. Their drug costs were so expensive. She felt like she had to keep working. And so the IRA, the Inflation Reduction Act, which has a few climate change provisions, but I like to call it the new drug benefit, really changed.
Well, that's the one that people it's so important to people's everyday lives, right? Like,
It
not
is
that climate
so
isn't, but in terms of like immediate need.
Yes, it's a need. It's not only a need for the people who are dependent, but I was recently listening to a panel with a Gen Zer talking about how she was worried about her own family's prescription drug costs and what it meant for her own life and own livelihood. And so the IRA changed and allowed Medicare to negotiate prices, which I'll talk about in just a minute. It also implemented some fundamental changes to the Part D program. Part D is our letter that the federal government uses to talk about most of the prescription drugs that are covered by the Medicare program. And some of the changes, there are many, but one of the things that I'm the most excited about is the catastrophic cap, which is in effect this year. Next year it goes down to $2,000. What a difference that makes, that people know eventually your costs will be covered. And there are already seniors who have hit that cap. It varies for people, but it's about $3,500 for this year. And there are already people who, again, take drugs that cost them out of their pockets thousands of dollars a year. I met a woman very recently who was telling me the story of her journey through leukemia. One medication was $13,000. That was 12%, 13% of her income. I mean, just one of these products. So this is a really exciting, I think an exciting moment for us to be able to offer a different level of hope to people. And part of the way we're doing that is by negotiating. So we're in the process right now. Our team is back at the ranch, led by our very able center lead, Dr. Meena Shashamani, and they are working in good faith with drug companies to try to negotiate a good deal for the Medicare program so that we can make sure that seniors and people who depend on Medicare can get access to the drugs that they need.
I mean, and in some ways, if you look at the sheer number of people that you cover, right? I mean, the kind of weight that you as an agency has, it's almost surprising that it hasn't happened earlier. You know, this negotiating power and the ability to go to drug manufacturers and say, you know, we have the population that is using your drugs, and yes, you can charge them a lot, but if people can't afford them, they're not going to buy them.
That's right.
And you know, of course, we're you know, not discounting their health impact at all, but I'm just saying from a financial point of view, which is what a lot of people, you know, focus on. And as you said, they make very hard choices about rent or food versus
Absolutely.
medications, and I'm sure you've heard all of those stories as well. So what do you tell people when they say, well, I'm kind of surprised to hear that, you know, this is the first time that CMS is actually negotiating in this way. Like, I kind of thought they always did, or why didn't they have this authority before?
It's such an interesting question. I mean, I think that the challenge, the joy and the challenge of a program like Medicare is that it is put together by a group of members, Congress, and whoever is president at the time. And there was a very stark disagreement when I was not on the Hill at that point. I was in the private sector watching to see what Congress would do. There was a debate and a compromise, and at that point, Medicare was not given the ability to negotiate. And I would say that we, as policymakers, have to just continuing to evolve. As we're talking about, drug pricing has become one of the most fundamental issues to the healthcare discussion, making sure that companies continue to be able to innovate, and everyone wants to make sure that companies can make a good profit and want to be coming up with new innovative drugs. We have to make sure that the American people can actually get access to them. And that is requiring a major shift in the way that the drug benefit was structured, which it was structured in a way originally that there is in Congress, you have a certain amount of money to spend, and they designed it in a way that some people who had a few drug benefits would feel that that was an attractive benefit and then dealt with catastrophic costs. But the number of seniors now that take, the averages are well over 7, 9 medications, which is even different than it was 10 years ago. Right. And as I said, I just think this issue is so compelling to people, and not just the Medicare program. It's very important as these exciting, innovative gene therapies come to market that affect Medicaid, that affect the commercial market. We need to make sure that the American people have access to them.
I'm glad you brought up the gene therapies, because that's a great segue into my next question, which is about, this past year we've seen, and we will continue to see, a lot of innovative treatments come on board and become available for patients. We've got a gene therapy for sickle cell now. Mm-hmm. We have exciting treatments for Alzheimer's, which is, obviously a big issue in the Medicare population. And for the first time in Alzheimer's, we have disease-modifying therapies. So these are therapies that can actually make a difference in the progression of the disease. So when you look at these first-in-class treatments that come out, they're completely innovative, never seen them before. They work in different ways. They also have different, if you think about it, kind of disease trajectories, right? Because a lot of these gene therapies in particular are meant to be functional cures in a way. Mm-hmm. And many of these people, especially in the case of sickle cell, face a lifetime of transfusions and procedures and hospitalizations, all of which drive up their healthcare costs. And potentially this gene therapy could significantly reduce, that healthcare, the healthcare need for them. So when you look at all of that, it's a restructuring too of the risks and the benefits and the cost effectiveness. How do you as an agency assess those new therapies and determine whether and how much they should be covered in your population?
So one of the features of the healthcare system is, as we all know, we have a very complex system. Some people are covered from private insurance, some people are in public programs, and a lot of our insurance is based on our employer. So if you change jobs, you may very well change health plans. And one of the issues that I think emerges, because that's the way our healthcare system is that when you have products or therapies that come to market that will save someone a whole lot of money in the future, it's not necessarily going to save the person that's paying for your drug costs or that therapy right in that moment. And so it can be challenging. And thinking about it, you're an employer and a new therapy comes to market and you're thinking, well, is this person going to be in my health plan in 3 years when the savings will come, in 10 years when the savings will come? And so as an overall system, that is sometimes a challenge for a particular payer, whether it's the commercial market, Medicare, Medicaid, to make that assessment. So then stepping into CMS's role, our role in coverage is limited, and it depends on which M we're talking about. So if it's in the marketplace, largely private sector plans are deciding about coverage. Certainly if it's a drug, they're required by our laws to cover it. If it's Medicaid, we have a bargain with the Medicaid has with drug companies that that drug will be provided if they give money back to the federal government. But it's been challenging for states sometimes to afford some of these incredible therapies, and which is a reason we have to think about trying to address drug costs. So some of the therapies that are coming to market, sickle cell being one of them, is disproportionately going to be borne by Medicaid and the commercial market. So our role typically is very limited when it comes to the Medicaid program, but we have an innovation center, which is able to do things a little outside the box, do experiments. We call them models, of course. And one of the models that we launched, our team, Liz Fowler runs our office, is looking at cell and gene therapies, and can we, as the federal government, help states be able to cover therapies, just knowing how much, A, they cost, and also trying to take into account other things. So on sickle cell, for those of you who know that space, one of the major issues is that the therapies can affect fertility, and really thinking about if you're a young woman, probably may or may not have met your partner, you're 18, 17, 19, you might be concerned about taking a drug that might affect your ability to have a child someday in the future. That's a piece where our Innovation Center can look a little more holistically, and our team is in the process of trying to see, can they help states develop a way to pay for the drug and also perhaps be able to offer these wraparound services. Because drug coverage and innovative therapies are not disconnected from the broader picture. Then, so that's our role with that M. With Medicare, our role can be, it's not always, but often is more forward-leaning. We have, when an innovative drug comes to market, sometimes those decisions are made by private entities that report up to us, but largely make their decisions across the nation. We use that language to say a local coverage determination. But in some instances, if we get asked by stakeholders, or if we see differences across the country, we do what's called a national coverage determination. We don't often do that, but we do in times. And we did get asked to do one for the innovative therapies that came to market for Alzheimer's disease. And it's our requirement by law to look and see if drug therapies that come in innovative products are reasonable and necessary for the Medicare population. And that is the approach that the agency takes.
So I want to delve into that a little bit because I'm sure many of you have been aware of kind of the back and forth over the coverage and reimbursement for these new Alzheimer's therapies, which all have in common that they attack amyloid, the protein that builds up in the brain. And because the very first one, aducanumab, had kind of a checkered history, through the FDA, the Food and Drug Administration regulatory process, in terms of the data that was presented, and eventually, I think, ultimately, by the end of this year, that drug, the manufacturer has said, they will take it off the market. But there is another drug that was approved by Eisai, called lecanemab, Leqembi, which works similarly on amyloid. But CMS Medicare made a decision to treat all of the amyloid targeting, anti-amyloid therapies as a group, as a class. And there were a lot of advocates in the Alzheimer's community who felt that that wasn't fair, and that, because of the kind of controversial nature of the first drug, that you were kind of tainting everything else that would come along. And they were quite upset about that, and there was a lot of controversy and criticism of the agency about that. Can you tell us about that decision and explain the reasoning behind that?
I'd be happy to, and I think this is one example, of one issue that I've really been trying to make sure that we as an agency do, which is really help people to understand better our decision-making process and how the process works. And I think this was a great example of, I think, people not fully understanding what CMS's role is and how the agency typically approaches issues. So when the first product came to market, which of course we should start with saying how devastating Alzheimer's disease is and affects not just the people who are affected by Alzheimer's disease and dementia, but also family members. I don't know that there's a family in America, including my own, not touched by it. When the team of clinicians really thought about how to approach coverage, one of the things that they decided to do was to look at the whole class, as you said, which I think people felt concerned about the existence of the history of the first product versus the future products. The reason why why we decided to look at the entire class is because that's actually the fastest way for us to cover a new product. So had we made a decision just on the first product, we would have made a decision on that one, and then when the second product came to the market, we would have had to start a brand new process, which takes many months. And so what the agency decided to do was, let's look at the data that we have so far, and that as new products come to market, if there's additional data that comes in that causes us to change how we want to approach it, we will be able to make those changes more quickly. And I think that's the thing that in the government, you often have requirements that you need to meet and timelines. And that was the decision and the reasoning that we wanted to make sure that as soon as innovative products came to market, that we'd be able to cover them and again, update them with additional information. But if we had to start the process over, it would have been a minimum of 6 months before we could start covering the drug. It probably would have taken even longer than that.
And especially with a drug like that, where intervening early, right, is critical, that would have made a big difference, I think, to a lot of American families. Yes. I wonder if you can also address you talked about the model for that you're doing for innovative care, and I know you've got several others as well, and in particular for maternal health, and that's such a big issue now, and there's been so much recognition of the gaps we have in maternal health care in this country, which really puts maternal mortality and infant mortality in the United States at such low levels compared to other nations, especially other developed nations. So can you tell us a little bit about that model?
Absolutely. Yesterday we had a wonderful panel on maternal health, maternal morbidity, and mortality in our country, and it is quite distressing to really understand how poor our health outcomes are, particularly for women of color. And I think it's really important whenever we talk about that to note that it's not just women who are low income and don't have access to health care. There are, of course, very high profile examples of women who have had poor health outcomes. If Serena Williams can have a challenge with our healthcare system, any of us can. So we have taken a number of steps in the agency to address maternal health and maternal mortality. But one of those is our model on maternal health, which we are very close to opening up the awards for. And the thinking around that is Medicaid covers 40% of births across this country. In some states, it's even more than that. And some of the things we know are there are best practices that are not being practiced during the care that people need. And one place that we have heard time and time again from engaging with stakeholders are how important doulas are, particularly for people who feel like they don't have an advocate. And so, among other things, we're providing assistance to states to really help them think about better ways to improve maternal mortality in their states, and over time will require them to cover doulas as part of their part of the services. So if a mother wants to have a doula, she'll have access to their services, not even just at the point of delivery, but importantly, before and after, because as we know, good health outcomes don't start when you are at the hospital giving birth. They start beforehand and very often after a couple months, as you're trying to make sure that you're getting the care you need, getting the care your new baby has, and all of the other things that go on in our daily lives.
When it comes to looking at the costs of our healthcare system, right? And you brought up one issue, but clearly there are a lot of gaps and there are a lot of deficits in how we deliver care, and that has really affected access and affected health outcomes. How is the agency looking at perhaps more innovative ways of providing care or increasing access? You know, I'm from New York City, and I see kind of increasing attention and support from the city for family caregivers, having them reimbursed and things like that. So those are like a little bit out of the box ways of thinking of delivering healthcare and providing services that are just as meaningful and important, but that perhaps don't require the more expensive versions of healthcare that our system now has. Like, how involved is the agency in supporting and perhaps starting to reimburse for some of those kinds of ideas?
Yeah, and I will take it M by M, as of course it's different in each program. When thinking about the Medicare program, we have some levers. Some are dictated by Congress, and then sometimes we have flexibility. One key area, you talked about caregivers. We have made in this administration providing caregivers and looking for opportunities just such a priority, and part of that is because increasingly people in this country need caregivers to get access to care, and our healthcare system has often overlooked the role that they play in making sure that people have access to the care that they need. So one way we have done really try to make sure that caregivers are part of the story is we are, for the first time in the Medicare program, paying for physicians, for doctors and nurses, paying them for the time that they spend with the caregivers, helping them to know how to care for their loved one when they leave the hospital, the doctor's office, for chronic illnesses. And so cancer, which of course, as we all know, is a huge priority for the President and First Lady, and given their own experiences of the help that you need with the people that provide those services. We're also trying to include that in our innovation center models. So paying, we're doing that in our guide model, which is related is for people with dementia, but also other models of really trying to say, are there opportunities for us to think about the caregivers? And certainly states through the other M are thinking about how they can incorporate a more holistic look at care. So whether it's caregivers, whether it's thinking about, I like to call them healthcare adjacent services. So do you have, asking when you are seeing a person, do you have access to food? Do you have access to secure housing so that you can tell me, is your knee pain related to your surgery, or is it actually related to the stress that you have in your life? Asthma, is that related to the fact that your home has mold in it? There are all these pieces that affect our health that we're trying to make sure providers are asking those right questions, and that we are thinking broadly, particularly in the Medicaid program, about making sure that people get the supports that they need to get the care that they need.
I think that's so important when you mention that health is not just about medicine, right, and the medical care, that in particular when we look across this country, there's so many other factors that are involved, like you mentioned, housing, food insecurity, and stress, and all of that. So one of the things I'd love to bring up and get your perspective on is prevention, because that really, prevention is all about not incurring those health costs in the first place. And I know that Medicare, again, set a precedent back in 2010 and approved reimbursement for the Ornish plan. And I know Dr. Dean Ornish was here this weekend, which is a vegan diet, exercise, stress reduction, meditation for heart disease, for lowering risk of heart disease, and Medicare is reimbursing for that. Mm-hmm. So tell us a little bit about kind of the vision and long-term view that you have on prevention and how important and what role it plays in when you look at kind of the categories of services that you reimburse for.
Yes, I think there is a growing appreciation and awareness of how important it is for us, our healthcare system, to be thinking about prevention, and that the system isn't always designed to encourage it. We often pay for care at the place of emergency rather than the further upstream, which I think we all know is crucial. I would say a couple of things, and I should absolutely mention that the agency has many people get their care through private insurance, Medicare Advantage, which about half of the people in Medicare. Many plans are also thinking about these services that I've been talking about and thinking about how to provide them. I would say prevention is key in a couple of ways. One, the Affordable Care Act increased the requirements around preventive services. So in Medicare, Medicaid, and marketplace coverage, there are increased requirements around preventative services being covered. But some of this is actually making sure that people go to the doctor and their primary care physician. And we have tried to make primary care, as far as we can within our own authority, to be paid better. We have, in recent rules, changed our Medicaid rules around putting an emphasis on primary care, maternal health, and mental health to really encourage that. And we try to do that in the Medicare program as well, although I will say some of our levers are limited in terms of if we pay one person, sometimes it has to be budget neutral, so we have to balance those. But we also look at that again in our models and our accountable care organizations, some of which are run in the core Medicare program and some of which are run through our Innovation Center, really trying to emphasize some of these other lifestyle changes in places that we can't necessarily, Medicare can't reimburse directly, thinking about how do we do that through these other vehicles. So
I think I would love to get your perspective too in looking at kind of long-term care, because as we saw that by 2050 the population of Americans over age 65 is expected to double, and clearly our current healthcare system places an undue burden right on the families, on the patients, to both find the care as well as pay for it. So given the responsibility that you have over that population, how are you thinking, knowing that this bolus is coming, how are you thinking of kind of re-envisioning perhaps some of the ways that we provide care? And you talked about like the caregiver issue and reimbursing providers for caregivers. That's one step, I'm sure. But also, as you anticipate that more people would potentially need long-term care and for chronic conditions, how are you looking at that coming problem or issue and thinking about ways to perhaps rethink the current way that we provide services?
Well, maybe I'll start on a light note as we think about the aging population and growing. I, as a Gen Xer, have full confidence that the baby boomers will make sure that we figure out this problem.
We're hearing from them. Yes, we are.
My husband and I joke with our parents quite a lot about how we knew that they're going to change the way we operate. And I say that in a joke, but I mean it quite seriously, because I think that we are seeing a shift in what the baby boomers want in their Medicare program and what they want in terms of long-term care.
And they have a point, because our current system is not doing the job.
That is absolutely right. And I think that it is a generational issue, which I think is important. Just speaking from my own life and my friend's life of juggling young kids and aging parents. It's an issue if we don't have secure health care for our aging population, for not just them, but of course the younger generations as well. And so that's part of the reason, again, why caregivers is such a priority. I think we all know, and COVID really affected our nursing home population quite disproportionately. We were all affected by COVID, but the two ends, the children and people who are older, had the longest, I would say, the most severe indications that we're still wrestling with. One of the things that I've heard, we've done a lot of listening sessions and discussions, and one of the things that I've heard from people who care for the long-term care population is just how the complexity of the people who need care has just increased. You don't think of opioid addiction as being something that people who are older are wrestling with, the behavioral health issues, the needs to manage those. And so we need a sophisticated workforce to take care of some of these challenges. Some of the ways that we are levers, although I will say I do think in the future, very soon, we are going to need changes in federal law to really address our long-term care needs. But what we have been doing in our agency is a couple-fold. First is really looking at nursing home staffing. And I think we all share the goal of wanting people, if it is the right choice for them, to be able to be cared for in our nursing homes. And the thing that we have heard time and time again is how staffing is correlated so strongly with health outcomes. And so part of what we have done is over time we're phasing in new requirements for the first time for nursing home staffing. And I think that we know it's going to be a challenge for many facilities, and we want to work with the industry to make sure that we have the workforce that will be available to care for our seniors and people with disabilities. But it's absolutely essential that people, if they go, you live in a nursing home, this is where you reside, we need to make sure that you can get a shower more than once a month. We need to make sure that you get turned over. We need to make sure that you're eating, that just all of these basic things. But of course, there are many people who don't want to live in a nursing home, and we should be able to, as the healthcare system, help keep people in their homes and community-based setting. I like to say the goal should be that you get the care in the appropriate setting. And for a whole host of reasons, our public programs really favor the institution and hasn't paid as well for home and community-based services. We've been trying to use our levers to improve that where we can. And so whether it's through looking at our models, or particularly in the Medicaid program where home and community-based services are provided for more broadly, really trying to encourage, again, that workforce is there, stronger standards in terms of payment, in the hopes that we will see seniors being able to be in their homes. And I should say it's not just, although it is not just seniors, which of course is a core part, but it's also children who have disabilities, as well as people of all ages. There are more and more people who are able to live when they have a car accident or other types of things. And so there are plenty of younger people who are in the situation where they need either home and community-based service care or nursing home care.
So I wonder if we could draw an analogy between what you just said about the proposed rules for staffing in long-term care facilities, and would it be similar to CMS and Medicare really kind of setting the stage for saying there needs to be X number of staff for X number of residents, or this facility won't get reimbursed for its services, right? And kind of set that as a precedent similar to the way it did for desegregation. decades
That's right.
ago.
That's right. And so, and I should say there will be an exceptions process, but we think it's so important to set a standard and to really aim for what we think is the minimum for making sure that people have are healthy and safe and secure in their nursing homes. But yes, this is the first time Medicare has said we're not going to reimburse unless you meet these standards. And I do think it is incredibly groundbreaking for the program to be saying that and setting a standard.
And you mentioned, too, that you think the federal law needs to change to address some of the gaps in long-term care. And because long-term care, again, with an aging population is going to be such a big part of our healthcare landscape, right, in coming decades, what are the areas where you feel law needs to change? Like, what do we need to do?
Well, I think that just going back to the core, the primary payer of long-term care is actually the Medicaid program. It's not Medicare. Medicare pays for very little of long-term care services. It pays for basically, with exceptions, of course, 2 weeks in a skilled nursing facility. Most of the dollars are from the Medicaid program. And we typically have thought of the Medicaid program as being for the working poor. The middle class are incredibly dependent on Medicaid, and people, when their parents need help or their loved ones, they're looking to the Medicaid program to cover those costs. Medicaid pays a disproportionate amount of those costs, and I see a state in the audience and will share just how much they have pressure when they're trying to think about, do we take care of the children? Do we take care of the adults? Do we take care of nursing home care? And the nursing home costs are a disproportionate amount of the money that we spend in the Medicaid program. And I think that that's a real issue when, again, Medicaid is meant to be the safety net. It's meant to be for the people who are at the lowest point of our income scale, and we should be thinking about that as a country, is that the proper balance for long-term care services to be reimbursed in that way.
And obviously part of that picture could be the Affordable Care Act, right, ACA, the marketplace. I mean, how, having been such a big player in the creation of that, and seeing it from really the early days and how it's played out in its current iteration, when you look at where it is today, was that kind of what you had hoped for, when this idea was first born? And where do you hope ACA will be, like, in the next 5-10 years?
It's about 15 years from when I was on the House, the Ways and Means side. I think we had just gotten all the way out of each of the 3 committees, and had no idea how long it would take to pass the legislation, and then thought that was the hard part. Didn't realize that
the fun was just beginning.
The fun was just beginning. I like to remind, there's a whole generation of health policy experts who know more than all of us, who came of age after the ACA, that they don't remember. Most of the members in Congress were not there before the passage of the ACA, have no idea how difficult it was and how different our healthcare system. Being a woman was a pre-existing condition. You could be charged more. You could only have some of your body covered by an insurance company. We have come a tremendous way of getting to the lowest uninsured rate of our nation's history. And I'm so excited that we've gotten that. I think of coverage, as I said, as necessary, not sufficient, but necessary to really making sure that people in this country have access to care. I think we have come a tremendous way in terms of eligibility, people being enrolled. We still have states that have not expanded Medicaid. There's still 10 states that haven't. And I think it's so important to really take stock of that. I mean, for the poorest people in this country to not have access to care is just, to me, unthinkable. And there have been 4 states that have expanded since the Biden administration began. And I've had the privilege of being with stakeholders at the start of their journey to get their states over the finish line, and talking to people who, for the first time, have health insurance, who had cancer, and a woman was just so relieved in Missouri that now she had coverage because her cancer had returned. Just these fundamentals. I hope for the future that we get to the point where everybody in this country has a M to go to. Again, happy for people to be employer-sponsored coverage, but we need to make sure we are covering these gaps. I think we've gone a tremendous way, the drug benefit, among others, in terms of really achieving access to care. Again, being able to afford your coverage, be able to see your doctor. We've strengthened the rules in Medicaid, particularly of trying to make sure that you can see your doctor. But there's more to go in terms of the care that people need. And long-term care is, again, one of those gaps as we think about how do we make sure that people have options through their entire life cycle.
Well, thank you. I know we could continue talking, but Chiquita, thank you so much for sharing your thoughts
Thank you for having
for
me.
the work that you do. It's so important for the health of so many Americans. Thank you.